All right, so my last video got cut off, so here we go. Take two. Consent was obtained and the patient received 2 grams of Ancef before incision. She also had visible anxiety and history of anxiety when I saw her in pre-op before we went back, so she received 2 milligrams of Versed for anxiolysis. For antiemetic plan, I gave her 20 milligrams IV famotidine in pre-op. Intraoperatively, she received 2 milligrams of Zofran or 8 milligrams of Zofran and 8 milligrams of Decadron as well. We also placed the OG tube just to decrease abdominal pressure and decrease the risk for aspiration. For multimodal pain control, I told you guys about the tap block that we did after induction. She also received PO, acetaminophen, and pre-op, and she received 4 microgram boluses of Precedex throughout the case just for multimodal pain control, as well as the 100 micrograms of fentanyl total throughout the case, 50 before induction, and then 2 doses of 25 throughout the case. And then the dexamethasone helps with multimodal as well. So for induction, I gave a 5 milligram defasciculating dose of rocuronium, 50 milligrams of lidocaine, 140 milligrams of propofol. After she had the loss of lid reflex, I found that she was easy to ventilate, so we proceeded with 100 milligrams of Sux. A 7 ET tube was placed using a McGrath. I chose to use a McGrath just because of her dentition and loose teeth, just to avoid any type of trauma. I had a grade 1 view and easy intubation. So after return of twitches from the sucks, I went ahead and gave 35 milligrams of rocuronium, and that was redosed twice throughout the case, just with 10 milligrams each time. Amnesia was maintained using sevoflurane at 1 to 1.5 MAC. She was placed on pressure control volume guarantee with a tidal volume of 425, respiratory rate of 10, FiO2 of 60%, and a PEEP of 5. For emergence, I chose to do an awake extubation just because of her high aspiration risk. I gave neostigmine and glycopyrrolate, 0.2 milligrams per 1 milligram of neostigmine. So the patient, she had 1 twitch before emergence, so I went ahead and used the dose of 0.07 mg per kg. So after she met all the extubation criteria, the tube was removed. Everything went well. She was able to maintain her airway and adequately oxygenate. She also exhibited adequate pain control post-op and hemodynamic stability. For her IV fluids, she was NPO for 8 hours, so there was a deficit of 880, and her maintenance were 110 milliliters per hour. Blood loss was replaced with crystalloid, so she received a total of 1850 mLs throughout the whole case, and the surgeon said the estimated blood loss was 250. So, yep, can't wait to hear your feedback.